Welcome to Airway Breathing Conversation, a podcast presented by the anesthesiology residents at the University of Saskatchewan, created to provide individuals of all levels of medical knowledge with anesthesiology-related healthcare information. This episode is part of our Abridged Ground Round series, in which highly knowledgeable and sought-after guest speakers present on a multitude of fascinating topics relevant to anesthesia. Join us for Ground Rounds this week, where Dr. Talha Gondal, a PGY3 anesthesia resident working right here in Saskatoon, discusses the perioperative management of opioid use disorder. Now, whether you are an anesthesiologist, resident, medical student, or member of the general public, come listen in as we demystify the incredible specialty that is anesthesiology, one episode at a time.
So before getting into the details of the talk, just outlining the objectives for today. First, we'll talk about why patients with opioid use disorder require a specific and deliberate perioperative management. Secondly, I'll go through the perioperative management of patients who are already on treatment for opioid use disorder, and particularly we'll discuss the medications methadone, naltrexone, and buprenorphine. And third, we'll discuss how to approach patients with suspected or untreated opioid use disorder who still require analgesia in the perioperative period. By the end of the talk, the goal is that hopefully we'll have reviewed some of the guidelines surrounding perioperative opioid use disorder management, which hopefully we can apply to these patients the next time we see them in the pre-op clinic, in the OR, or on call. So just to provide some background and context, it's important to look at the current state of the opioid crisis because it does explain why we're seeing more and more patients with opioid use disorder in the perioperative setting. So here's just a couple stats from Stats Canada. Uh, Between January of 2016 to June of 2025, there have been over 53,000 apparent opioid toxicity deaths reported in Canada. So it's not a rare problem. It's something that's been a sustained public health crisis, and it continues to affect the patients that we care for. Looking specifically at the first half of 2025, about 57% of those opioid toxicity deaths, they involved fentanyl. Um, and the same proportion involved fentanyl analogs as well. Another key point is that 68% of deaths also involved a stimulant, such as meth or cocaine. And this just highlights that polysubstance use is increasingly becoming a more and more common with even one substance that a person might be using. Finally, it's worth noting that Canada saw about 17% decline in opioid-related deaths in 2024 compared to 2023. So overall, there is a trend of decreasing opioid-related deaths, and this is the same in the United States. Now, while this is overall encouraging, the absolute numbers are still very high. And so the takeaway here is that opioid use disorder is common and it's often complex and often related with polysubstance use as well. So let's look a little bit closely into substance use disorder in the hospital. Um, Up to 40% of patients presenting for elective surgery have some form of unhealthy substance use, and about 20% report illicit drug use. So even when we think about routine optimized pre-op population, substance use is still quite frequent there. When we look specifically at hospitalized patients, about 10 to 30% have a non-alcohol related substance use disorder. And that can include opioid stimulants and other substances as well. Um, Patients with substance use disorder are more likely to leave hospital against medical advice. From a perioperative perspective, this can potentially increase the risk of missed postoperative complications, inadequate pain control, as well as overall poor follow-up, and it can be a reflection of untreated withdrawal, uncontrolled pain, or a lack of trust with the healthcare system. So, what exactly do we mean when we say a patient has opioid use disorder, and how is it diagnosed? Opioid use disorder is a clinical diagnosis, and it's often defined using the criteria from the American Psychiatric Association's DSM-5. I'm not going to read through every line on this slide, but I want to highlight how the criteria are organized and why that matters for us perioperatively. Broadly, the criteria fall into four domains, as you can see on the screen. That's impaired control, social impairment, risky use, and the pharmacologic criteria. The first is impaired control, and this includes taking opioids in larger amounts or for longer than intended. And these features, they reflect a loss of control. The second domain is social impairment, and this includes failure to meet obligations at work or home, as well as interpersonal problems. And these often reflect a negative impact to a person's work, home, and school life. The third domain is risky use, and so this is using opioids in a unsafe manner, or continuing to use it despite knowing it's causing harm to one, whether that's physical or psychological. And the fourth domain is pharmacologic criteria, which includes tolerance and withdrawal symptoms. A key point here is that tolerance and withdrawal alone, they do not count towards the diagnosis if a patient is taking opioids in a prescribed manner under appropriate medical supervision. So, such as, for example, in the case of chronic pain or cancer-related pain, where a person might be prescribed opioids long term. And so, chronic opioid therapy alone does not equal opioid use disorder. The diagnosis is made based on a number of criteria met within a 12-month period, and it's often the severity of it is classified as mild, moderate, or severe. Now, the takeaway here is that obviously we as perioperative physicians, we don't need to formally diagnose opioid use disorder, but many of our patients may meet these criteria if not explicitly documented. Recognizing these patterns also helps us anticipate withdrawal, higher opioid requirements, relapse risk, and just overall, just the need for a thoughtful perioperative plan. So, what about treatment for opioid use disorder? What we find in the literature is that only about 25 to 35% of people with opioid use disorder are being treated for it. And 20% of those receive medication for their treatment. There's, of course, many obstacles to treatment. Some of those include transportation, stigma, and the availability of opioid use disorder medication prescribers. So, before we go into how to manage these patients perioperatively, it's important to understand why medications for opioid use disorder matter in the first place. Um, Medications like methadone and buprenorphine, they um, they have been shown to reduce mortality. And here I've presented a systemic review from 2017 and a meta-analysis by Sardo and colleagues. I believe this one was published in the British Medical Journal. And They pooled data from multiple large cohort studies and they looked at all-cause mortality in patients with opioid use disorder while they were on opioids agonist therapy compared to periods when they were off of treatment. So these graphs here, as you can see, what they represent is that when patients are actively receiving methadone treatment, their mortality drops rapidly and substantially within weeks of starting therapy. In contrast, when patients stop treatment, mortality risk increases again, particularly in the early period after stopping therapy. So as you can see in the chart at the top here, it shows that while these patients are in treatment, you can see that the overall all-cause mortality rates are much lower as compared to when they're out of treatment. From a perioperative perspective, this can be important to be aware of and know the importance of these medications and the impact that it has on these patients. Here's another study. This is a 7-year cohort study from France. It was published in a family medicine journal in 2017, and they looked at a large. They used a large national primary care database, and they followed patients with opioid use disorder who were prescribed office-based buprenorphine. And then they tracked periods when patients were on treatment versus off of treatment. What they found was consistent with the systemic review, of course, that mortality was significantly lower during periods when patients were actively receiving buprenorphine, and mortality increased when patients discontinued treatment. The highest risk was seen in the time shortly after stopping buprenorphine, uh, which is which is likely related to the loss of tolerance and relapse. The key conclusion from the study, of course, as I already mentioned, is that buprenorphine, like methadone, is associated with a substantial reduction in mortality when continued, and interruption of therapy does carry a real risk. So why is this important for anesthesiologists? Again, we encounter these patients quite frequently in the pre-op clinic, an elective slate, as well as on call. And pretty much every setting that we practice, it's possible for us to encounter these patients. Um, Patients with opioid use disorder can either present to us on stable medical treatment, whether they're on methadone, buprenorphine, or naltrexone, while others can present untreated or even actively using. So each of these scenarios carries a different risk and requires a slightly different perioperative approach. Now that we've kind of established why medications for opioid use disorder are so important, I want to briefly review the three main evidence-based medications. These are the three FDA-approved medications for opioid use disorder. The first is methadone. It's a full mu opioid receptor agonist, um, and it's typically dosed once daily for opioid use disorder, often ranges from 80 to 100 milligrams for opioid use disorder. Um, it's usually dispensed through a structured opioid treatment program. And one of the advantages is that it's effective for both opioid use disorder as well as chronic pain. And we'll go through some of the more uh, detailed considerations for that shortly. The second medication is one that we encounter more frequently perioperatively is buprenorphine. And this is a partial mu opioid receptor agonist with a very high receptor affinity. It can be prescribed in various different medical settings, and patients may be on a wide range of doses for it. The third medication is naltrexone. This is a mu opioid receptor antagonist. This can be available as a daily oral medication or as well as a long-acting IM injection. Unlike methadone and buprenorphine, it's not an opioid and it does not provide analgesia. So as we move forward here, I just wanted to, before we get into this specific perioperative recommendations and guidelines, I just wanted to highlight three key reviews and guideline papers that this talk is largely based on. Of course, there'll be other studies that I'll highlight as we move forward, but I just wanted to show these up front so that if anyone is interested, they can go back and review these papers in more detail. The first one shown here on the left is a review that was published in Anesthesiology in 2019. And it's specifically written for anesthesiologists, and it provides a broad practical framework for management of patients with opioid use disorder. And the second paper, this was published in Anesthesia and Analgesia 2021. It's a expert consensus statement, and it's endorsed by multiple professional societies such as ASRA, ASA, American Academy of Pain Medicine, and the American Society of Addiction Medicine as well. This one is primarily focused on buprenorphine, but again, it does touch on a lot of the things that we'll talk about today. The third one, this one I just found is a very good summary paper, and it has everything that we'll talk about in this talk in a very succinct manner. So just put it there for reference if anybody wants to go see it. It was published by Harrison and colleagues in 2018 in one of the surgical journals. So let's start by talking about methadone. Methadone is a mu receptor agonist. It's a full mu receptor agonist, but it also activates delta and kappa receptors. When it does activate the delta receptors, one thing to note is that it desensitizes them. So this can be important for decreasing tolerance. So it can be helpful for patients who might have tolerance and as well as hyperalgesia. And then it does have some activity as a kappa receptor agonist as well, which is the kappa receptor, which is responsible for sedation and euphoria. Methadone also has NMDA activation, and this can be helpful for neuropathic pain, and again, circumventing hyperalgesia. Some papers noted that it has some serotonin and norepinephrine reuptake inhibitor activity. Again, this can be an important consideration when considering other types of medications that the patient is taking. In terms of its half-life, it's quite a long half-life, which is helpful for opioid use disorder as it allows once-a-day dosing. So 22 to 24 hours is what's quoted here. However, to note, and as we move forward with regard to some of the preoperative considerations, the analgesic half-life of methadone is much shorter, and it's about 6 to 8 hours. And so this will become apparent when we talk about dosing it in hospital. Again, another aspect to be aware of is that methadone is available in PO and IV forms. And lastly, it's important to consider QT prolongation when it comes to methadone. And so, especially when in the perioperative period, when we're giving other medications that can increase this becomes more of an issue when patients have been on methadone for a long period of time and with higher doses. And of course, the increased QT can put a patient at risk of arrhythmias like torsades. So we'll talk about the preoperative methadone management. So really the key principle is that daily methadone therapy should be continued throughout the perioperative period. Holding methadone provides no benefit and it exposes patients to unnecessary risk. So what we should be doing is we should check and verify the patient's home dose and confirm when the last dose was taken. And whenever possible, it's important to communicate with the patient's primary prescriber or clinic, especially in cases where there's uncertainty around dosing and complex cases. Because methadone has a long half-life, severe withdrawal is uncommon if a single dose is missed. However, continuing methadone does help avoid early physiologic and hemodynamic effects of withdrawal. In the setting of emergent and urgent surgery, if the patient has not received their methadone dose that day, the recommendation is to administer their usual daily dose. So, if oral dosing is not possible, then methadone can be given intravenously, and you can use an approximate oral to IV conversion ratio of 2 to 1 or 1.2 to 1 conversion from oral daily dose, which can be given as IV. And finally, because as we had mentioned earlier, that methadone is associated with QTC prolongation, it's important to review any recent ECGs preoperatively, especially for those patients who are on higher doses and those with therapy for a long period of time. Intraoperatively, things to be aware of is that these patients may require higher intraoperative doses of opioids. Even though methadone can reduce opioid-induced hyperalgesia, opioid tolerance and hyperalgesia can still be present. And so our, standard opioid dosing may be insufficient. Second, it's important to remain mindful of QTC prolongation. And if a patient already has prolonged QTC, we should try to avoid or minimize additional medications that would further prolong the QT interval. As well, another thing that we can consider doing is ensuring electrolytes are optimized, especially if you're seeing a patient with prolonged QT. Finally, and probably one of the most important points that you'll see throughout this presentation is that we want to maximize multimodal analgesia. And relying solely on opiates for these patients is rarely effective and often will lead to escalating doses without good pain control. And so incorporating regional anesthesia whenever appropriate, neuraxial techniques, as well as our non-opioid adjuncts, all of these can significantly improve the analgesia and reduce opioid requirements. Postoperatively, the patient's home methadone dose should be continued postoperatively, unless there's a clear reason to reduce it, such as hemodynamic instability, respiratory depression, or significant changes in mental status. Routine dose reduction is not recommended. And to improve analgesic benefit in the acute postoperative setting, it can be helpful to actually divide the daily methadone dose rather than giving it once daily. This is commonly done by splitting the dose into 3 times daily, which takes advantage of methadone's shorter analgesic duration, which was 6 to 8 hours, compared to its long half-life. So consider dividing the dose and giving it TID whenever we encounter these patients in hospital. If the patient is NPO, methadone can be given IV, and a commonly accepted approach is to give approximately that ratio that we just talked about of 1 to 1.2 versus a 1 to 2 dose going from IV and PO. So if you're going from PO to IV and somebody's on 80 milligrams and you use the 1 to 2 ratio, which is the more conservative one, and we'll talk about this shortly, you can just divide their daily dose in half and then divide that dose further over 24 hours. And so 80 milligrams PO can be given as around 13 to 15 milligrams IV TID. Another point to keep in mind is that any additional short-acting opioids used for postoperative pain should be tapered as soon as clinically reasonable and appropriate. And this is just to avoid unnecessary escalation and prolonged exposure um, uh, to short-acting opioids. Finally, especially in more complex cases, it's important to involve addictions medicine or communicate with the patient's primary prescriber. And this often comes into discharge planning and it may or may not come in front of us because we're often just seeing patients post-operatively and we may not see them directly at discharge, but it is a point to consider. I just want to briefly discuss oral to IV methadone conversion. There isn't a lot of good evidence and studies kind of looking at this, but the couple that I did look at, I just wanted to present here. This study here comes from the journal Palliative Medicine, and it's from 2020. It's a multi-center randomized control trial that looked at patients with controlled cancer pain. So a little bit of a different setting, who were being switched between IV to oral methadone. They compared two strategies. One was the 1 to 2 traditional ratio, and this is also what's recommended as per the FDA, versus a more conservative ratio of 1 to 1.2 ratio. And again, just highlighting here that this study specifically looked at IV to PO, whereas we will often be dealing with converting from PO to IV. So using a 1 to 2 ratio actually is the more conservative ratio when going from PO to IV. Here's another study. This one, yeah, again, looked at conversion ratio of PO to IV methadone of 2 to 1. Um, And what they found was they specifically were looking at bioavailability of methadone, and they found that the bioavailability of methadone is around 85%, and 75 to 85%, I should say, and that oral to IV conversion ratio of 1.3 to 1 is more appropriate than the commonly used 2 to 1 ratio. So again, the data is overall scarce with in regards to this conversion ratio, but overall, it may be safe to just take a more conservative approach to use the 1 to 2 ratio when converting from PO to IV, and just be ready to titrate. I'll shift now to naltrexone. We won't spend too much time because we won't. This is a bit less common as compared to methadone and buprenorphine, but it does have important perioperative implications. Pharmacologically, naltrexone is a mu opioid receptor antagonist with weaker antagonist activity at the delta and kappa receptors. Unlike methadone and buprenorphine, it's not an opioid and provides no analgesic effect. It's available in two forms, an oral tablet, which can be taken daily, and a long-acting IM depot injection that's administered usually on a monthly basis. These formulations, they do behave differently perioperatively, and it's important to be aware of that. Uh, so the half-life of oral naltrexone is relatively short. It's around 4 hours, but its opioid receptor blockade can last longer than the serum half-life. In contrast, the IM depot formulation has a very prolonged effect. It has a functional half-life in the order of 5 to 10 days, um, but it can result in sustained opioid receptor blockade for weeks. So when it comes to the preoperative naltrexone management, unlike buprenorphine and methadone, as we've already seen, and buprenorphine, as we'll see, which are best continued throughout the perioperative period, naltrexone uh, may be discontinued before elective surgeries where acute opioids are anticipated to be needed. Um, the recommendations from those reviews and guidelines was that to delay surgery wherever possible to 28 days, especially where uh, major surgery or surgery anticipated to require at least a moderate amount of analgesia with opioids. It should be delayed if possible. And this is especially for those who are on the IM form. There's no consensus based guidelines for naltrexone specifically, um, but this is what was mentioned in those reviews, as I mentioned. Uh, if naltrexone is to be held, the time interval to ensure opioid receptors are completely unoccupied is likely 48 to 72 hours for the oral form, or 21 to 28 days for the injection form. Again, the time interval may be adjusted on a case-by-case basis according to the patient risk and risk factors for relapse as well. Naltrexone can potentially be continued in the perioperative period in certain circumstances. So, for instance, many patients on long-term naltrexone regimens are committed to an opioid-free recovery and they may refuse discontinuation or just the risk of opioid exposure. So, in those cases as well. Um, Additional scenarios when naltrexone might be continued is a minimally invasive surgery with low opioid requirements, so such as like carpal tunnel release, or surgeries where local or regional anesthetic can reliably be provided without a significant post-operative pain. Patients who did not stop their naltrexone before unanticipated surgery, so an emergent surgery, they can be managed with opioids. However, high doses are likely going to be required, and appropriate monitoring um, for for adverse events is important. Intraoperative management of naltrexone, just a few considerations here is that it largely just depends on whether the medication was discontinued prior to surgery or not. If naltrexone has been appropriately held, then short-acting opioid agonists can be used for intraoperative pain control. Um, uh, Opioid requirements can still be unpredictable, and so it's a careful titration is important for these patients. Um, Regardless of whether or not we choose to use opioids for these patients, again, the key point is to maximize multimodal analgesia. And another important nuance is that these patients who have been on long-term naltrexone, they may have altered sensitivity to opioids. So once the receptor blockade resolves, so some patients may appear opioid resistant, while others may be unexpectedly sensitive due to receptor upregulation. For that reason, if opioids are used, the safest approach is to start with low dose and titrate carefully to effect with close monitoring for both inadequate analgesia and oversedation. Postoperatively, depending on the time interval of the last dose of naltrexone, patients may, again, as I mentioned, present with unpredictable opioid sensitivity. Um, and it's important to recognize that they may be likely more susceptible to opioids, but it depends on how long they've been on naltrexone and whether when their last dose was. When it comes to discharge planning for these patients, there's limited data on reinitiation and what the best course for that is. Although the FDA current guidance advises 7 to 10 days of opioid abstinence before starting injectable naltrexone, um, this may or may not apply to post-surgical patients receiving short courses of immediate release opioids. Um, Again, the time interval to restarting naltrexone should be considered on a case-by-case basis, and it depends on the timing of the last dose, the duration of the dose, as well as additional patient risk factors. Um, some of the guidelines mention that you can consider an oral naltrexone challenge before redosing the longer IM injection, just to monitor for acute withdrawal. Overall, there should be good coordination with the primary prescriber, as well as both the anesthesia and surgical teams, to be involved, and to make a opioid taper plan for these patients, and ensure that there's a plan for reinitiation. Next, we'll talk about buprenorphine. So Buprenorphine, it was actually initially created as an analgesic. It's pharmacologically, it's an opioid agonist and antagonist. It's a partial agonist at the mu opioid receptor. And it also has agonist activity at the opioid receptor ligand 1, um, which helps with the analgesic component as well. But at the same time, it acts as an antagonist at the kappa and delta receptors, which contributes to its ceiling effect on respiratory depression and its efficacy in treating opioid use disorder. A key feature of buprenorphine is that it has a very high binding affinity for the mu opioid receptor. It binds more tightly than most full opioid agonists, and which means that it can displace other opioids from the receptor. We'll talk about this in a bit more detail as well. In addition, buprenorphine has a slow dissociation from the mu receptor. Once it's bound, it stays there for a long time, and this is why adding standard doses of full mu opioids on top may sometimes appear ineffective. The half-life is long, particularly with the sublingual formulations, typically 28 hours and even up to 60 hours. And so this just means that the receptor occupancy persists well beyond a single dose interval. Buprenorphine is available in multiple formulations, most commonly encountered as Suboxone, which is buprenorphine and naloxone. The naloxone component is just there to deter injection misuse, and it has minimal effect when it's taken as prescribed. So, what does a high binding affinity for the mu receptor actually mean? Um, What it means is that it can displace other opioids and prevent other opioids to bind once buprenorphine is in place. However, important point to keep in mind is that some receptors may still remain available and unbound. Um, Buprenorphine can precipitate withdrawal because withdrawal is driven by a sudden drop in your mu opioid receptor activation and not simply by loss of receptor occupancy. And so, in patients with full mu opioid agonist on board, receptors are highly activated. But when you have buprenorphine introduced, it has a very high receptor affinity, so it will displace those full agonists. But because it's only a partial agonist, it'll have a lower intrinsic activity. So overall, the receptor activation can abruptly drop, and this rapid decrease, despite receptors remaining occupied, produces acute withdrawal symptoms. It does have some kappa and delta opioid receptor antagonism, which potentially improves mood and mitigates emotional dysregulation, which is common in opioid use disorder. Overall, it's safe in the elderly, those with chronic renal disease and hepatic insufficiency as well. Um, Next, this is just a chart highlighting the dosing for buprenorphine as well as some of the formulations and indications. The only thing I want to highlight from here and take away is that buprenorphine can be prescribed for both opioid use disorder as well as for chronic pain. And oftentimes for pain, you'll see that the dosing is in micrograms versus the dosing for opioid use disorder, which will be in milligrams. Just want to briefly talk about buprenorphine receptor occupancy, as this is important to understand. Um, Basically, this comes from studies looking at PET scans where mu opioid receptor availability is shown at different doses of buprenorphine. You'll see on the screen here different PET scans. And as you can see, as the dose increases, you have less and less available mu opioid receptors. And there's been other studies done showing and kind of comparing the dosing to what is an estimated receptor occupancy as well. Clinically, why is this important? First, patients on typical maintenance doses of buprenorphine, they already have substantial mu receptor occupancy, which means that adding a full agonist may have reduced or a blunted effect, especially at standard doses. Second, it does highlight that if we were to stop buprenorphine shortly before surgery, often it does not necessarily mean a meaningful reduction in receptor occupancy because of the drug's long half-life and slow dissociation. Receptors can still remain occupied for days, even if the medication is held. And third, it also just kind of reinforces why all of the guidelines that we're reviewing today, they'll recommend continuing buprenorphine perioperatively rather than stopping it. This table just puts some of those numbers that we talked about, and it shows an estimate for receptor occupancy. As you can see, most people will actually be on 16 to 24 milligrams at their higher end of doses. Rarely will you see 32 milligrams, but again, it's possible for you to see that as well. But at the doses of 16 milligrams, usually the receptor occupancy is around 80 to 95%. Again, these were all based off of neuroimaging and pharmacokinetic studies. A couple other systematic reviews that I'd like to highlight. One is from the CJA in 2019, and all of which, as will come to the considerations here perioperatively, will recommend the continuation of buprenorphine. This is another a study. It was a practice advisory and interdisciplinary group recommendations. This is one study, a more recent one that was just published in Anesthesiology. And I just wanted to highlight it as it was one of the more recent ones from what we're seeing. And again, it just reinforces that continuation of buprenorphine is is actually more beneficial. And so this was uh, it looked at adult veterans in the U.S. on buprenorphine on Suboxone specifically, and who underwent surgery, and then they compared the two groups: patients whose Suboxone was continued perioperatively, and patients whose Suboxone was interrupted or held around the time of surgery. So this was large-scale longitudinal data, and the primary outcomes that they examined were post-operative pain scores as well as post-operative opioid utilization. Um, and what they found was that patients whose Suboxone was continued and had similar or better postoperative pain control compared to those whose Suboxone was stopped. Um, in contrast, patients who Suboxone was interrupted required higher doses of opioids postoperatively as well. So again, continuation of buprenorphine and Suboxone was not associated with increased opioid related adverse events, such as respiratory depression. So, in other words, again, it's just another study highlighting that the recommendation to continue Suboxone and buprenorphine throughout the perioperative period is more beneficial to patients even in terms of pain. So again, in summary, buprenorphine should be continued. Um, Overall, um, you pose the risk of relapse with no clear benefit when you discontinue it. Um, Again, you want to confirm the home dose. And then, very importantly, set expectations early and create a plan with the patients. And they should understand that the postoperative pain may be more difficult to manage and that opioids will behave. They may behave differently, and that the plan will rely heavily on multimodal analgesia. And I think just having the conversation preoperatively and early on, it can improve trust, reduce a patient's anxiety, and potentially even decrease conflict around pain management after surgery. Again, highlighting the importance of maximizing multimodal analgesia. The recommendations do mention that using short-acting full mu agonists when multimodal analgesia is inadequate is okay to do. Um, and uh, there was a recommendation which they graded as grade C, which was low level of certainty, that you can consider increasing and or divide the doses of buprenorphine with close monitoring for uncontrolled pain if and when multimodal analgesia is inadequate. And lastly, a taper plan can assist in minimizing withdrawal and decreasing post-operative opioid use, as well as maximizing successful discontinuation of the short-acting opioids once pain has returned to a manageable place. This is just a summary of what we've talked about, of the recommendations to continue buprenorphine. And again, always considering multimodal analgesia, as that's very, very important for all of these patients that we talk about. Next, I'll finish off by talking about patients who present with suspected or untreated opioid use disorder. This is also a group that we encounter frequently, and oftentimes this can be something that's also missed. So just highlighting the importance of preoperative assessment, that it just needs to be deliberate when we see some signs and symptoms of substance use. So it's really important to have a good substance use history, including what substances are being used, how often, the last known use, and as well as the typical amounts and quantity. There's also signs on physical exam that we can look out for. Again, this is all on a spectrum where it can be from all the way from acute intoxication where you look for signs such as slurred speech, sedation, and constricted pupils, um, as well. Looking for injection sites or infected skin, it can raise concerns for bacteremia or endocarditis as well. Focused cardiorespiratory exam is always important. And another important point is that dental decay can also be a clue to chronic substance use. In terms of investigations, not a whole lot, but if available, and for example, somebody who presents acutely in the trauma bay or coming from the emergency room, a drug screen can sometimes be helpful. It can just clarify a specific drug sometimes, but not necessarily recommended to order one all the time. Again, an ECG is useful, especially to screen for QT prolongation, especially if methadone exposure is suspected. Finally, again, important to discuss the pain plan and expectations early with all of these patients, as well as with the surgical team as well. Here's just a couple risk factors for opioid use disorder that we can consider. So males, a young age, psychiatric disorders, so people with depression or anxiety pre-existing puts them at a higher risk. Long-term opioid use, other alcohol, substance use, um, and then some key signs and symptoms which we went over, but just highlighting here again, just looking out for these on your clinical exam. Lastly, I want to briefly talk about whether or not, is there any evidence to show that buprenorphine should be administered in hospital when we identify patients in hospital with having opioid use disorder? Or who have suspected opioid use disorder. Um, there are a couple studies. The one I've highlighted here in front of you on this chart, it just highlights that patients who are being hospitalized and who had suspected opioid use disorder. Um, it showed that the first 28 days after hospital discharge carried the highest risk of drug-related death, which was far higher than later periods and higher than in individuals who were never hospitalized. So, um, importantly, this just shows that there's an increased risk for these patients at hospitalization and directly after that. And that can be a vulnerable time for these patients. And so another important aspect to here is that hospitalization is also a moment where these patients may gain insight into the impact of the substance use on their health. And they're often they may be more receptive to treatment discussions and willing to engage in care. This is another study. In this study, hospitalized patients with opioid dependence were randomized to either buprenorphine initiation with linkage to outpatient care or detoxification and referral alone. So this was an RCT uh, done. And the key finding was that the patients started on buprenorphine in hospital were significantly more likely to be engaged in addiction treatment at 30 days. And they reported less illicit opioid use compared to those who underwent just detoxification and referral alone. So this trial just supports the idea that hospitalization isn't just a place to stabilize patients medically, but it's also a window to initiate evidence-based addiction treatment that can have meaningful changes in outcomes for these patients. Pharmacologically, there's also reason to initiate buprenorphine due to its good side effect profile relative to other opioids. As you see on the chart here, it just explains why buprenorphine behaves differently from the full mu opioid agonist and why it changes how we manage perioperative pain for patients on it. On the left, you'll see that the full mu opioid agonist, if you note this orange curve, increasing the dose leads to increasing opioid effect and including analgesia and respiratory depression, but it has no clear ceiling. In contrast, if you look at the blue line, buprenorphine demonstrates a ceiling effect. And so analgesia does increase initially, but then plateaus. And importantly, respiratory depression plateaus at a much lower level. And so this is the major contributor to its improved safety profile. So I want to briefly review how buprenorphine can be initiated, even though most anesthesiologists here in particular, we may not be the primary prescribers, whether that's to do licensing scope or follow-up requirements, or even overall just how the system is set up. That said, it's still important for us to understand this process because we frequently will encounter these patients during hospitalization in the perioperative period, as well as during care transitions, where we may identify untreated opioid use disorder, or we may be involved in consultation as well. So what's shown here, there's multiple approaches to initiating buprenorphine. This one that's shown on the screen right now is a low dose or microinduction strategy. And this allows buprenorphine to be started without requiring the patient to be in full opioid withdrawal. So small doses, as you can see, are introduced gradually while continuing baseline opioids, which just minimizes the risk of precipitated withdrawal, as we spoke about earlier. This one can take several days, and so it may not be the most ideal to initiate in the hospital setting. However, the recommendations from that multi-society expert panel, they included this recommendation and algorithm. Um, and overall, just kind of going through it, what they recommend is that if a patient is on a PCA in hospital, and you're planning to initiate buprenorphine, then you hold the PCA whenever appropriate for 1 to 3 hours. Give a low dose, 2 milligram um, Suboxone sublingually, and then wait 1 hour, reassess for withdrawal. And then you can continue to give 2 milligrams of the Suboxone sublingually as tolerated every 1 hour, monitoring for pain as well as a withdrawal. They recommend overall maximum of 16 milligrams every day. And then again, having some sort of discharge planning for these patients and follow up, whether that's with medicine specialists or an outpatient prescriber for buprenorphine. Again, just overall summarizing what we spoke about is that for buprenorphine, consider starting it for patients with suspected opioid use disorder. Again, this um, should be done likely in consultation, especially when you're doing it for opioid use disorder. Should be done in consultation with addiction medicine and the team, of course, responsible for the patient. Um, and very important to facilitate the linkage to outpatient follow-up for these patients. Interestingly, the guidelines, those multi-society guidelines recommended that buprenorphine may be safer for outpatient settings for patients with suspected opioid use disorder, even if follow-up with outpatient buprenorphine provider has not been established. So just to wrap things up, and with the key take-home points. The first is that communication is absolutely essential. These patients do best when we communicate with them as well as the other our other colleagues involved in their care are all on the same page. Secondly, multimodal analgesia, as we've mentioned many times in the talk already, is that it really matters in this population. So whenever possible, considering regional anesthesia, Tylenol scheduled, NSAIDs when appropriate, um, ketamine, Precedex, and all of our other adjuncts. They're actually core components of care for these patients. And lastly, for patients with suspected or untreated opioid use disorder, you should at least consider buprenorphine initiation. That decision often will involve addiction medicine, but as perioperative physicians, we do play a key role in recognizing the risk and triggering that conversation potentially. Overall, the goal is not perfect pain control, but a safer and more thoughtful perioperative care that reduces harm, relapse, and overdose risk.
You've been listening to Airway Breathing Conversation, a podcast hosted and presented by the anesthesiology residents at the University of Saskatchewan. Please note that while this podcast is run by healthcare professionals, it is intended for educational and entertainment purposes only. We are very thankful to our guests for taking the time to share their wisdom with us this episode, and a very special thanks to you, our listeners, for tuning in. Don't forget to follow us and our associated USask Anesthesia accounts on social media. You can find all our social media links on our Linktree page at linktr.ee/abc_podcast. You can also find the department's social media links on their Linktree page at linktr.ee/usask_anesthesia. We'll see you next episode, but until then, stay calm, take a breath, and always remember your ABCs.